Welcome to Healthy Living, where we delve into pressing health issues that affect you and I as Nigerians. Today, we'll be delving into a condition that is widely misunderstood, faced by stigma and fear. Today, we'll be talking about epilepsy. In our last episode, we had a moving story by someone who is living with epilepsy, and I would say that story was marked by strength and stigma. That is why we're going to be trying to understand truly what epilepsy is from the medical perspective on the show today. To help us unpack medical risk factors, and basically all the facts around epilepsy today on Healthy Living, I have with me Dr. Mimi Osad Osamwonyi, consultant neurologist, Maitama District Hospital. Thank you so much for joining us, doctor.
Yeah, thank you. Thank you for having me.
It's a pleasure. Let's begin with the basics. How would you describe epilepsy?
Okay. So basically, epilepsy is an excessive discharge of neurons, of course, in the brain, that leads to symptoms that can span from motor symptoms, where the popular one that most people know are convulsions. It can be episodes of emotional burst or abnormal behavior or abnormal sensation. So that basically is what epilepsy is. But anyone who has a seizure doesn't necessarily have epilepsy. There's a definition for epilepsy by the International League Against Epilepsy. So when someone has had seizures at least 2 or more seizures, at least 24 hours apart, then we can make a diagnosis of epilepsy. Or someone has the typical, what we refer to as epilepsy syndrome, even with just one episode with the EEG findings and MRI findings, we can come together and say, okay, this is epilepsy.
So what happens in the brain at that period? Can you give us a description?
Okay, to make it simple, so we have two basic kinds of neurotransmitters in the brain. So some of them are excitatory and some of them are inhibitory. So when there's an imbalance, when we have the excitatory, there's more of excitatory compared to inhibition, then there would be excessive firing. Or if there's too little inhibition to match the excitation, then there will be, excessive firing of the neurons.
Is there an easier description for the layman who does not understand the big medical terminology?
So the neurons, which is the basic cell units of the brain, they're always talking to each other. They're always communicating. That's how we get things done. That's how we reason and all of that. So when there's excessive firing, so there can be seizures.
So what are the risk factors? Are they specific risk factors that people should be aware of?
Oh yes, there are risk factors for seizures, for epilepsy. When there's a when one has a genetic disposition to it, when there's a family history of seizures, when someone has had a stroke, for example, whether hemorrhagic stroke or infarctive stroke, someone has had a brain injury before. What else? Then infection, even if it's an abscess or meningitis, that's an abscess in the brain, for example. Those kind of things, after a while, the person can be predisposed to having a seizure. And of course, there's the category of those that we do not know why they have seizures.
Wow.
Yes.
What are the symptoms? What are those things to look out for beyond the seizures to say, oh, there might be a trace of epilepsy in this person, be it a child or an adult?
Okay, so basically the symptom or the sign is actually the episodic attack that the person has, whether it be motor or non-motor. So the common one that most people know are the jerks, abnormal jerks, all right, which we describe as tonic or clonic seizures, or there's even the absence seizure where the person just gaze, that is common in children, where they just gaze into space and they are not aware of what's going on, and then you tap them and they come back to reality. So that can happen many times in a day. So yes, there are motor seizures and non-motor, like when the patient is just not aware, just staring into space. And sometimes it's just the atonic seizures where they just fall like a pack of cards, where we have exude some level of tone to keep our body posture and all of that. So sometimes there's a loss of tone and the person just falls. It's just falls down for a few minutes or a few seconds and then recovers.
How bad is this regular seizure on the brain over time?
or the effect of this. Oh yeah, so there are billions and billions of neurons in our brain, and the more people have seizures, the more the likelihood that you lose some of these neurons over time. So, for example, if someone's IQ was, maybe in the 90th percentile, and the person keeps having seizures over time, uncontrolled, the person's IQ can begin to drop and things like that. So, yes, it can affect someone's level of cognition over time.
Are there treatment options, management options that do not necessarily turn out to lifetime medications, or what are the medical options to, treatment for one with epilepsy?
Okay, so first of all, the diagnosis of epilepsy has to be correct. We have to make sure that this is epilepsy. This person has been having seizures, and yes, it is epilepsy for the person to qualify for, treatment. And then when you find out, okay, this is epilepsy, what type of seizure does this person have? Because different seizure types respond better to certain medication. And then, of course, the person's demographics, as in is male, female, and then the year, the age of this patient. So these inform what kind of medication each of them is going to get. So it's not a situation of all one cap fits everyone. So everyone gets a unique prescription depending on the gender, the age, and of course the type of seizure that person is having. So there is the pharmacological treatment, right? And we usually start with a low dose and typically increase over time, and watching to see that till we get to the point where the seizure is well controlled. Then there are non-pharmacological measures that we can take. And by the way, most times we start with one drug, which is monotherapy. And if we are not achieving control, we can add another one to it. So they can be, a patient can be on 2 medications. Then for the non-pharmacological part of the management of a patient who has seizures or epilepsy is the avoidance of triggers, which is very, very important. I mean, someone who is taking his or her drugs regularly, but he's refusing to sleep and is, in quotes, creating content online at night and not sleeping. So, I mean, the person is telling you, I'm a content creator and is working all night, and then gets very sleep deprivation, you're going to trigger seizures. Or someone is stressed, or there are different things that trigger seizures in people. So they also have to look out for those triggers and manage them while they're taking their medications. Of course, there's also room for, very rarely though, surgery.
Okay.
All right, where the lobe or that part of the brain, or where the seizure is emanating from, is excised and all of that. Of course, that has to do with a lot of precision. It's in the purview of the neurosurgeon who does all of that. So yes, there's a place for that, and then there is a place for diet, the ketogenic diet for patients who have seizures. But popularly, what we use basically is avoidance of triggers, and then of course taking their medication regularly.
So let's talk about myths and misconceptions. There are notions that it has a spiritual attachment. How have you, what's your medical perspective to that, and how have you handled such notions that you've come by when it comes to informing or talking to people about epilepsy?
Of course, coming from the medical angle, we know that we generally try to encourage our patients, for example, that okay, this can be managed. Okay, so if you take your drugs, if you avoid the triggers, you can be fine, and you can actually go to school and live out your dreams, and get married and all of that, because those are real concerns that people have, and in fact, because of all of that, they try to hoard information, not giving full disclosure of what's going on, and that even predisposes them to even having more seizures, and they're not taking their medications and getting help, like professional help that they should get. So basically, it's just counseling and talking to people. And then when you tell them, when they see other people, for example, when they come to clinic and they're seeing other people who are having, well, we don't really have support groups yet, okay? Maybe hopefully in the future that will happen. Maybe there are some that I'm not aware of, but large scale, that's what I'm referring to, that is well known. but that would really help, where people can, have conversations with other people who are having seizures and finding that people are living their normal lives and they're moving around and things like that. So basically it's just counseling and talking to people and letting them, reassuring them that they can achieve control and they can live normal lives.
One myth that has sparked reactions among people, I would love to get your thought on that, is putting a spoon in someone's mouth when they're having seizures. How do you think that came about? What is your take on that?
Well, I'm not sure of how that came about, really. If I'm going to say anything on that, I'll just be imagining or thinking, because, someone's teeth is clenching and you just think that, this person may bite his tongue or tongue. I think I need to put this. So those are one of the do's, don'ts that we tell people not to do. Just don't do that. Don't just clear the space, and remove anything harmful. Don't try to put anything in the patient's mouth.
So what do you do when one is having seizure at that moment?
Okay, so actually so basically you just take away anything that, because the person is jerking, you don't want the person to hit himself on anything and sustain any form of injury. Just create space and allow the patient to have the seizure, and then when the person recuperates, you put the person in the left lateral position, just a comfortable position, and then this is at home or somewhere, then bring the person to the hospital. Of course, if you're in the hospital, we'll do all of that and then quickly give a drug, diazepam, to abort the seizure.
Okay.
Yes.
So what are the most common misconceptions you've encountered in your experience that you would love to debunk when it comes to epilepsy?
I'm trying to think.
The most dangerous?
Most dangerous? I think the most dangerous would be just taking traditional medications. Some people just feel they need to go and see someone somewhere, and they mix a concussion for that person to be able to, because along with that, apart from it's not really controlling the seizures, they now end up having things like either toxicity to the kidneys or to the liver and things like that by the time that they get to us and all of that. And another thing is that they also suffer other complications like shoulder dislocation, and they would have had so many seizures that at the point in time when they are coming, they now are not, they're having some form of, if it started in childhood, for example, developmental delays or things like that, and where they're not able to go to school properly, like they should have. Their age mates are far ahead of them, and that also comes with some form of depression and low self-esteem and things like that. So those are the issues, really.
So although we spoke about treatment option, is epilepsy a lifetime situation that one has to deal with, or is completely curable?
Okay, well, we manage epilepsy. It's more or less lifetime. Okay, so this is the approach. So basically, when someone has epilepsy, we usually ask that they do a brain imaging, typically a brain MRI, at least 1.5 Tesla, to see if there's anything in the brain, for example. So if we do a brain MRI and we can see that there's a tumor or there's some cyst and all of that, that's where the triggers are going to be coming from. That's where the firing is going to be coming from. Except that disappears, it's not likely to stop. So yes, it just goes to show that that person is going to be on drugs for pretty much all of his or her life. The only time when we consider the possibility of withdrawing the medication is if you have an MRI that doesn't show any abnormality, for example, and then the person has been on his or her medication for 2 going to 3 years and has been seizure free. You may want to repeat the EEG and begin to pull out the drug very carefully. Now, we do this with caution because when a patient has seizures, the person can, and God forbid the person is driving or swimming, the person can harm himself or harm people around. You don't want that to happen. So that's why we're very, very careful. So a lot of times when patients are in a hurry to have their medications pulled out, I like to tell them that, look, it's for your own safety, okay, and the safety of those ones around you. God forbid you're not even driving, you're just walking along the road by yourself, and you're trying to make your way home, and you have a seizure, and people are wondering what's happening to you. you could endanger yourself.
So let's talk about the costs, because we spoke about it. How would you rate the cost of maintaining the lifestyle of, you're living with epilepsy? How do you maintain the cost for medications, for the MRI, for the EKG? How cost effective or how cost alarming is it?
Okay, well, quite frankly, it's quite costly. And then depending on where you do the EEG, it may be from 25,000 to 60,000 to 70,000. Then the brain MRI, because it's not a CT scan that we typically request for, and in fact, at least a 1.5 Tesla, you'd be saying somewhere about 160,000, at least over 150,000 naira. Well, it's not an investigation you do routinely, really. At least at the start of your when we are being evaluated, yes, at least that should be somewhere documented that you have done it. Or maybe if there's changes in the future, we may want to ask for a repeat of either or both. All right, so that is expensive. And then the drugs in itself. So very recently, due to the naira dollar rate and things like that, a lot of pharmaceutical companies actually left the country, leaving the drugs to maybe some third-party individuals. So that has actually affected the availability, not even just the costs, the availability of these drugs. And you find a patient moving from one brand to the other. Doctor, I've checked everywhere, I can't find this drug and all that. So what I would say to this is where NHIA comes in, okay? And some of these drugs are actually covered by NHIA. And even if you are not a civil servant or you're retired, there are packages for, that you can sign up to, and begin to have, access to these medications.
Let's talk about society's attitude towards people living with epilepsy. In your experience and with patients you've come in contact with, how has this stigma affected how they open up to you or even come for medical advice or consultations?
Okay, so I think that the kind of patients I see has largely been influenced by this environment. I believe that if I was in Zaria, for example, where I studied, where I trained, or somewhere more rural, maybe I would get more of those people who really, really feel they have all this experience this stigma. I would just say, like, for one or two patients, that maybe someone who in the township brought all the way, like, because the person was locked up, and not going to school, not even getting proper care, and someone says, "No, bring this person to Abuja where I am. Let's take care of this person." And this child was behind in her education and things like that. So that's just to say, in this environment, I don't see much of that. I think most of them are either parents or siblings or people who are educated, and these are their loved ones, and they are not hiding. They want them to be okay. All right. So basically, from my own end, I think that's okay.
So what role would you encourage families usually to play when it comes to supporting their loved ones who are going through this?
Oh yeah, support in terms of emotional support. Being there for them when they're having this, and not to even look down on them, knowing that, look, this can be managed, knowing that, okay, they're coming together to help them meet their appointments, ensuring that they take their drugs, come to hospitals, that's meet their appointment, take their medication, and then help them manage triggers, because for example, if you have husband and wife, for example, the wife is having seizures and the husband is insisting, you need to cook this, you need to do this, you need to do this and all of that, he has to be mindful of her status so that she doesn't have seizures. And then maybe they're in their childbearing period of their marriage and they're having children, they also want to share in the burden of carrying the child or not nurturing the child. Because I've had a situation where the mother had a seizure, baby was on the floor, mother was on the floor recovering. I mean, you don't want anything to happen to your wife or your child. So support is very, very, very important.
All right.
Yes.
Thank you so much, Doctor. Quickly, would you want to give a call to action, show it to the society on the attitude towards people living with epilepsy? Okay, my call to action would be people living with epilepsy can live a very normal life. Okay, so don't look at them as some strange people and all of that. They need your support. They actually need your support. They can actually live very normal life and become
very useful and contribute to society at large. So yes, they need everyone's support. Thank you.
Thank you very much,
All
Dr.
right,
Mimi.
well.
From our conversation today, it is clear that the narrative needs to go from fear to facts. People living with epilepsy are just like you and I, and they require support. With that, we've come to the end of Healthy Living this week. Thank you so much for joining us. Do not forget to follow us across all our social media platforms for news, programs, and a lot more documentaries. My name is Lilian Ogazi.